for the Introduction to the Healing Community study. For those of you that don't know, the goal of the study, which was to test the impact of an intervention that we developed called the Communities That Heal intervention on overdose deaths and associated outcomes in 67 highly impacted communities across 4 states in Kentucky, Massachusetts, New York, Ohio. We took our 67 communities and randomly assigned them to either receive the intervention first, we call those Wave 1 communities, or to be waitlisted and receive the intervention at a later time. The baseline characteristics of our communities, you can see that overall we're touching over 10 million lives through the Healing Community study, with very high rates of opioid overdose deaths at baseline. We realized the importance of having both rural and urban communities because one solution that might work in a rural area doesn't necessarily work in an urban area and vice versa. So I'm going to talk about the components of the Communities That Heal intervention next. There are 3 of them. First is community engagement because it is a community engaged intervention. The second is the opioid overdose reduction continuum of care approach, or ORCA, which is a menu of evidence-based practices known to reduce risk of overdose. And then the third are our communications campaigns. In thinking about community engagement, HCS went into these 67 communities, and in some cases they built coalitions from scratch, and in other cases they built on existing, mostly prevention-related community coalitions to be able to work on more on the sort of treatment and harm reduction side. We also had some key positions within communities that we selected and that we supported. One, each community has a community engagement facilitator, and they serve as a liaison between the coalitions and the communities and the study staff. Second, we have media and communications champions, and they really help to facilitate the dissemination of media campaign messages and help us with all of our communications efforts. We have data champions because the intervention is a data-driven intervention. We help them to pull together their own data, and then we provide them with some data through the study, and to be able to use that to make decisions about what kinds of evidence-based practices might have the highest level of impact, and then to monitor that over time. Then we have people from the communities that work on data dashboards. Each of the 67 communities received a data dashboard from the study that they could look at, that we tried to, as much as possible, have real-time data that was being displayed on things like overdose hotspots, as well as places where people were receiving naloxone or medication for opioid use disorder, and then eventually displaying the strategies that they selected for implementing evidence-based practices, and doing some ongoing monitoring to see how those different strategies were progressing and the impact of those, so that they could then make changes if they were needed as quickly as possible to their strategies. And then we have implementation specialists that really help coordinate the implementation of evidence-based practices within different types of community organizations. The work with communities in terms of community engagement goes through a 6-phase process. We begin with phase 0, which is preparation, which is the work that really we did behind the scenes even before we were introducing ourselves to community members. And then we moved all the way through, phases 1 and 2 is really about beginning to work with the communities, beginning to help them to get organized, introducing them to the evidence-based practice menu, helping them to understand that and how that can be helpful to improving their communities and lowering overdose deaths and improving things like treatment outcomes. Then working with them in phase 3 on those dashboards and that data. And this all sort of culminates in phase 4. Where each community develops a tailored action plan. And that action plan is where they select how they are going to go about implementing those evidence-based practices on that ORCA menu, and who they're going to partner with, and what are those concrete, tangible steps they're going to take to be able to try to reach more people with those evidence-based practices. And then in phase 5, after the action plans are developed and communities agree on those and decide on those, then we're really implementing the action plan and monitoring it in an ongoing way. And really important for the Healing Community Study is sustainability planning, because we did not want, as soon as the study ended, for the interventions that have been stood up to end. We wanted them to be able to continue. If gains are being made in communities, the last thing you want is when a research study winds up and we leave that community for them to have no ongoing access to that intervention and to those evidence-based practices. Let me talk a little bit about the ORCA, which is the menu of evidence-based practices. That's the second part of the intervention. The ORCA is a menu of EBPs that have a lot of robust research, meaning it's not just one or two studies, but it's a whole body of work that supports the ability to reduce overdose death. And so there's three components to the ORCA. The first are strategies that look at increasing opioid overdose education and naloxone distribution. Naloxone is the medication that can reduce an opioid overdose if it's administered in a timely fashion. The second is to enhance the delivery of medications to treat opioid use disorder, for which we have three now: buprenorphine, and there are different formulations of buprenorphine, methadone, and naltrexone. And then the third is to continue improving prescribing of opioids in a safe way. The ORCA also includes technical assistance guides and training from both outside as well as within the study on the evidence-based practices. This just shows from a conceptual perspective, and that you can see how the different menus map onto that full continuum for people who were at risk and using opioids to be able to prevent overdose fatalities, all the way through those who are in sustained recovery. So that includes things like opioid overdose prevention education and naloxone distribution. And then for those who have an opioid use disorder, that includes the effective delivery of medications for opioid use disorder. And at a community level, what you're trying to do is get more people initiated onto MOUD, and then it's really important to engage them and retain them in treatment and keep them on their medication. We were successful beyond our wildest dreams in helping communities in Wave 1 and Wave 2. You can see that communities implemented over 1,000 of the practices, which really demonstrates the utility of the process as well as the strategies. 439 around OEND, 393 around MOUD, and 203 from safer prescribing. Now I'm going to talk about the third part of the study, which were our public health communications campaigns. We're really proud of this endeavor. It was something that really energized and galvanized our communities. They loved working on the communications campaigns, and it's something that really brought together diverse community members from all across different sectors. We did the communications campaigns with the intent of increasing the adoption of evidence-based practices through the reduction of stigma, and also through wanting to build demand for the EBPs. And we targeted providers, community members and leaders, and people with lived experience. And the topics included naloxone, MOUD, and staying on MOUD. We put together these toolkits to help communities to think about how to form a communications campaign. And then we had some great people that worked on helping them to develop their specific materials. You see some of those here. And these print materials could be used on anything from a coffee cup sleeve to a coaster to a billboard. The messages, and with the toolkits and some additional in-depth information that could be put out throughout the community, like a half-a-page flyer that explained more about naloxone, for example, or a short little infographic that explained the 3 different types of medication. They were able to tailor those products. So if they had local community members that were willing to be the face of the campaign, it provided the opportunity to have faces of community members, but also in the background, If there were landmarks like a particular bridge or a particular statue or building that everyone knew and recognized, we would have that in the background of the pictures as well. It just provided that really local community connection.